I just want to reintroduce Dr. Carrie Mendoza here from Fair in Medicine. And we welcome everyone to our webinar tonight about the Endocrine Society and the guidelines and the issues surrounding those. We have folks filing in, so we are just going to get started here. I want to introduce our two panelists. I'm so thankful for Do No Harm and their partnership to be with us tonight to help educate us on this issue. We have Dr. Roy Eappen. He's an endocrinologist, a fellow of the Royal College of Physicians of Canada, and a fellow of the American College of Physicians. He graduated from McGill University in Montreal, where he still works as an assistant professor of medicine and teaches medical students. He joined Do No Harm as a senior fellow because of his concerns with today's young people. We're also really fortunate to have Ian Kingsbury. He's a social scientist and director of research at Do No Harm. He began working on healthcare issues when he observed that public health and health policy research had become deeply politicized, eschewing rigor in favor of fashionable and politically progressive politics. So we're really excited to have both Ian and Roy with us tonight. We're going to talk about the Endocrine Society and guidelines related to gender dysphoria. It's an issue that's very important to our community of Fair in Medicine. We have parents, clinicians, doctors, therapists who are all really wanting to understand more and just discuss what the issues are. So we're so happy tonight to be able to have our experts. Also behind the scenes, we've got some volunteers, experts, endocrinologists, and other expert researcher who will answer questions in the Q&A. So please put your questions there rather than the chat. So I'm gonna first go to Roy and just have him set the stage with just some, basic definitions for our community here. Just talk about, what is gender dysphoria, and just help us understand that, and then an overview of, puberty blockers, and cross-sex hormones, and the rationale for using them. So I'll pass it over to you, Roy, to start with that.
So I'm going to talk about what the definition of gender dysphoria. So gender dysphoria is a term that describes a sense of unease that a person may have because of a mismatch between their biological sex and their gender identity. And this sense of unease or dissatisfaction may be so intense it can lead to depression and anxiety, and it may have a harmful impact on daily life. That's what the definition of that is. And we're going to talk mostly about children today because I think that's where we really should concentrate. Puberty is a state where in the maturation of all humans leading up to fertility, and puberty starts off somewhere between 9 and 12, 9 and 15. And what happens is a part of the brain called the hypothalamus starts a series of processes which start increasing testosterone in boys, and increasing estrogen in girls, and it leads to secondary sexual characteristics, and then eventually it leads to gamete formation or fertility. So I wanted to talk about the guidelines. So the guidelines for people with gender dysphoria, for adults are one thing, but for children, what is suggested is that if these children have these feelings before puberty, the cross-sex hormones, that is giving the hormone of the opposite sex to the child, is not recommended. But what is recommended is to cut off that process in the brain that starts off puberty. And that drug is called Lupron. It is an LHRH analog, which basically blocks that process from happening. So You don't make testosterone and you don't make estrogen. Now, estrogen and testosterone have all kinds of effects. So you are cutting off many, 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 many things that are happening. I'm sure we don't know all of the things that those hormones do. So it's thought by the people recommending this that giving those blocking those hormones has minimal effects, but we're talking about blocking these hormones for long periods of time. The other part of the guidelines is the diagnosis of these conditions should be done by people who are well versed in psychiatry or mental health issues, and people especially in children, it should be a multidisciplinary team. And I'm finding more and more that that all kinds of people are making these diagnoses. People at all kinds of organizations which are not necessarily well versed in mental health issues. So our whole point for all of this is to try and get these guidelines to be reassessed. I think the guidelines in terms of the puberty blockers are without very much evidence and probably should be stopped. So we decided that we would try and get the Endocrine Society to reassess these guidelines. So we wrote them a letter, and we also had a booth at the last Endocrine Society meeting. The Endocrine Society is a large organization of 18,000 endocrinologists. Endocrinologists is a specialty of internal medicine, and it involves the study of hormones. So hormones are chemicals that are produced in one place in the body and act on a different place in the body. And it's primarily an American organization, but there are members from all over the world. And it is very important in the area of gender dysphoria, because their guidelines will be listened to because they're such a large organization, such an important organization. There are other organizations that make guidelines, but the Endocrine Society is one of the biggest. And you can see that by some of the recent judgments on some of the laws about transitioning of children, where the Endocrine Society guidelines are quoted on a number of occasions. So I'll leave it to Ian to tell you somewhat about our experience when we did a booth at the Endocrine Society meeting in Chicago a couple of months ago.
Sure.
Yeah.
So
yeah, go for it, Ian. Yeah, share that experience and how, things, I think, of how the guidelines in the States, the Endocrine Society guideline is from 2017 and hasn't updated, significantly. And then there's a lot of changes in Europe with them really looking at the evidence and saying there should be much more caution based on looking at the new evidence. So share with us, kind of some of those differences and our experience at the Endocrine Society in the booth and what happened there.
Yeah, so the three of us were there, me representing Do No Harm, which is an organization that seeks to end the marriage between politics and healthcare and to fight the woke takeover of healthcare. We were there because we have grave concerns about pediatric gender medicine, both about the ethics of whether a child can consent to these irreversible treatments, which I think the answer is that they cannot, but also the degree to which evidence is being sort of fabricated or misinterpreted. So our goal at this meeting was to ask for an updated systematic review. As Carrie alluded to, the last one was done in 2017. Sorry, they didn't even do a systematic review. That was just guidelines that they issued. But, that's basically what we're deferring to at this point, or what doctors are deferring to in making these decisions. And, in the world of medicine, 2017 might as well have been a century ago. And especially, I think, when we're talking about the space of pediatric gender medicine, I don't think it's probably a secret to anyone that the penetration, the infusion of gender ideology has become so extreme since that time that never mind whatever evidence has come out since that time to potentially inform the topic, but we're talking about a very different cohort of kids. The number of kids who are receiving puberty blockers or cross-sex hormones or surgeries in the span of only a few years. There was a study yesterday actually that just came out in the Journal of the American Medical Association, going like surgeries increasing by 500% among those ages, I think 12 to 19 in the span of I think it was 4 years. So, when we're, again, 2017 is a very long time ago. So it's time to revisit what the evidence actually says. Part of what also animates the urgency around this is that the Europeans are revisiting the evidence and they are launching systematic reviews. This has been done in Sweden and in the United Kingdom and in Finland. And in all of those cases, what the systematic reviews concluded was that the benefit-risk ratio was not favorable. In fact, the Swedes were saying for puberty blockers that the risks exceeded the potential benefits. And so these countries that are actually bothering to look at the evidence and not flying blind are universally reaching similar conclusions that this is dangerous, and they're changing their policies. And so it's time for the Endocrine Society and other medical organizations to go through that same rigorous process.
Yeah, that's exactly right. And all of us, at FAIR, Do No Harm, other groups, we want to have the open conversations and discussions rather than just saying, oh no, this is the way it is. And Europe is clearly much more open-minded in this regard to look at the evidence, and also because of that increase that you were describing of like patients that have come in, and there's different theories around that, ROGD and other influences that now we're seeing coming out, a group of patients that are really being harmed, that this was not the right diagnosis. And so yes, we really want our professional societies to step up and look at all this new information. Do you want to share what it was like being having a booth at the Endocrine Society and some of the people that we talked to, and how that experience then led to you and Roy writing a great op-ed in the Wall Street Journal that then had a catalyst effect that was really great. I'd love for you to share more about that. Yeah.
Sure. In terms of some general observations, one thing that was really interesting was, of course, it's an international conference, so there were a lot of European practitioners there. And there's a massive cultural difference in terms of their sort of willingness or the acceptability of even talking about these things. So for the European doctors, they would come up and just have like these really candid conversations and expressing surprise that the US isn't also going through the reckoning that's occurring over there. But you didn't there's no culture of hush hush. At least they engage with one another and they talk through these things and they want to have these conversations. And when it comes to American doctors, there were certainly the vast majority who came to us would say, we understand your concerns, or we quietly agree with you on these issues. But it's hard to get folks to say that publicly because it puts a target on their back. You have, whether it's the Endocrine Society or any other major medical organization, they tend to treat this as settled science. And so for a doctor to come forward and say, I have concerns about what's being done here, there is a massive professional cost to all of that. And so the culture of all of this really needs to change because, they really allude to there being a consensus around this. And that's simply not true. This was another thing that we observed. Like there really are a lot of American doctors who understand that this is a problem. If there's one thing that I would hope to see change, it's sort of that restoration of a culture of open dialogue and free speech, because I think that stifling of debate really has done an enormous amount of harm here.
Right. And you know, when you train in medicine and work in a, you know, I'm hospital based, but you know, it's true for clinics too. I mean, safety and speaking up about potential safety issues are just part of the culture that you learn. But why this is like a Bermuda Triangle where people go in and they kind of like all the normal things that we do in healthcare are, you know, sort of lost is really something we all struggle with. But again, we're committed to having these conversations and showing up and saying, hey, you know, we really want, you know, folks to pay attention to this and really look at it. So you guys wrote a great Wall Street Journal op-ed, and I put that in the chat. And then what you got a response from the new president of the Endocrine Society.
Yeah, the new president.
Yeah, you could share about that and you know, the concerns around, you know, what he wrote in terms of accuracy and that type of thing. I think it would be important to share with everybody.
So the new head of the Endocrine Society wrote a letter to the editor, basically saying that there were many articles, and the 18,000 endocrinologists all agreed with him, and sort of dismissed our concerns out of hand.
Just to backtrack a little, I think we should explain maybe the concerns that we expressed.
Oh, sorry.
Yeah, go for it.
No, please.
Yeah. So we basically wrote Ian actually had the idea to write an op-ed telling about our experiences and at the Endocrine Society, and we actually, I was quite pleased that everyone was polite and cordial, and it was quite a pleasant conversation. But in our op-ed, we asked the Endocrine Society to reassess the guidelines. The guidelines are 5 years old, almost 6 years old now. There are systematic reviews, even by Americans. I mean, there's a systematic review from 2020 of the Endocrine Society guidelines, which was not particularly positive. So we thought that should be done, and then we got this. In response, Dr. Hamas basically said that our concerns were not really valid. If I were him, I probably would have said nothing, but he did say something, which gave Ian and I a chance to reply.
Yeah, and there was more from there. So we had a chance to respond to that, and then there was further dialogue. So there were parents of gender dysphoric youth who wrote in and said basically, you know, we've been through this whole journey and we really want to understand what's actually going on here. And then even more important, not more importantly, but also very importantly, these 21 experts from around the world, I think 9 different countries wrote in, many of them from some of the European countries I mentioned that have done those systematic reviews that are reversing course, and taking the president of the Endocrine Society to task and saying, you are wrong here to be professing certainty about this. We have done what you are not willing to do. We've looked at the evidence and we're extremely concerned. So this was it was a really important moment in the history of this, you know, this debate, because unfortunately the activists often, they like to pretend that these things aren't happening in Europe, or they mischaracterize what's happening. So in London, for example, where they closed down the Tavistock clinic because it was deemed to be unsafe for children, they say, oh, that was really just about decentralization of care. So there's this history here of mischaracterizing it because, of course, you know, the political truth of admitting that these very socially liberal countries are reversing course on that, like that, it makes it very hard for them to sort of maintain the myths that they believe in, right? You know, for a long time here, it was sort of a he said, she said. they were sort of like interpreting what the Europeans were doing in a politically convenient way. And so finally, and gracefully, and we're so appreciative, those experts came forward and said, no, this is what we're doing and this is why we're doing it. So it's, for anyone who is still in denial about this, it's very clear that the US is an extreme outlier when it comes to so-called gender affirming care. Other countries are, they are reversing course on this.
Right. Where, the Dutch had started this, and then things got expanded, and then there's definitely contraction in Europe in terms of, again, just looking at the evidence base, but the evidence base is based on humans, human experience and patients. And so when you're looking and saying, well, there's a mismatch here, or patients are getting harmed, or, there's detransitioners who are saying, well, actually, the diagnosis was wrong because now I've experienced this treatment and I'm coming out the other end saying, well, that actually didn't cure what my issues were going in. And, I think there's so many, conflicting, thoughts and ideas in this whole area, where on one hand, we think some of this is really one of the reflections of like consumer generated healthcare, especially in the US, where it's like, well, the patient knows and respect what the patient wants. But then when we have patients who are saying, wait, I'm telling you this didn't work and I don't want this, all of a sudden, this other group is saying, oh, well, those people don't count. So it's like cognitive dissonance. It doesn't really make sense. You can't say like the consumer patient, they know what they want, but only if they agree with, our side. So those are just some of the hallmarks of like activist medicine. That's not normally how, medicine is practiced, and that's not a hallmark of, high quality evidence. And then I think what you all did so masterfully too was engage with the parents, the parent population who just, they want the best for their kids. And it's been very, very confusing for parents and scary if you go to a pediatrician and there's issues, and then you're like funneled into this system that just seems to be like, once you go through the door, you're on a certain pathway that can't be stopped. And I think, a lot of parents have concerns. And so you guys engaging with those parents and having them write a letter is extremely powerful and important. And again, having activists or people saying that they care about patients, but all of a sudden they don't care about what these, parents are saying about the treatment of their children doesn't make sense at all. So maybe, you Ian or Roy can just talk about how guidelines are, important, what you've seen in the legal realm. Harm has been so great helping to, you have, model policies and experts. Yeah, sure.
Could I just make a comment about the detransitioners for a second?
Of course you can.
So one of the most powerful things we did at our booth is we brought one of the detransitioners, a great person named Chloe Cole, came, and she is fearless, and she spoke to everyone she could. And I think that really sort of gave a second pause to even some of the members of the guidelines committee actually were there, and one of them spoke to her and was quite I would say shaken by some of the things she said. That she had surgery at the age of, I think she was 15 at the time, and they repeatedly kept saying to her parents who that, do you want a live son or a dead daughter? So this risk of suicide, which I think is somewhat exaggerated, the numbers are not clear at all on that, have really made parents very scared.
It's the Endocrine Society itself that admitted that the evidence is unclear whether there's any link between pediatric gender medicine and suicide. And the leading expert in Finland, in fact, said that this is, what did she call it? I think purposeful misinformation or something.
Yes.
What happens is that the doctors go to the parents of a child who's expressing gender dysphoria, and they say, you can affirm your child expressions of dysphoria, or they're going to kill themselves. You can have a live son or a dead daughter, right? And it's, it's crazy that they're saying this. It's not an evidence-based statement. There's no indication that this is true. And sorry, just to not to circle back too far, but to piggyback on something that Roy was talking about, a lot of the concern rightfully is on what the guidelines themselves are saying. I think especially the recommendation from the Endocrine Society that kids can start puberty blockers from the first signs of puberty. So like he was saying, kids as young as 10, 11 years old. That of course is a mistake, but another profound problem that I don't know I fully appreciated until we were there at the meeting was that there's not a lot of adherence to the guidelines necessarily. And
exactly right.
So you have activist practitioners who are so sure of this and feel so righteous about this cause that they just ignore the guidelines anyway. And you do read these accounts of a child going to a gender clinic and being prescribed puberty blockers after a single visit, which is not, it's not really consistent with the guidelines, but a really big part of the problem here is the way that the activists have come into that space and just, totally winging it in a way that's ultimately going to be very harmful to children. And this was Chloe's story as well, right? She was referred for top surgery after like a very short amount of time. She was 15 years old.
Yeah, no, thank you. Yeah, go ahead. No, go ahead, Roy.
As to guidelines, as they say, they are guidelines. Unfortunately, some of your courts seem to take them as dogma, and that's problematic because they're supposed to be guidelines based on the best evidence available, and I don't think that's what we're seeing in these particular set of guidelines.
Right. Yeah. No, go ahead, Ian.
And to the last question that you asked about the legal system,
yeah.
Now that some states are trying to shut down this practice, of course, it ends up getting thrown to the courts, and sometimes the challenges are at least initially successful because the judge, the judge is not, they're not a doctor, they're not a statistician, they're a legal expert, and so it's not really their responsibility to try to make sense of evidence. It's it's to look at what experts or so-called experts are saying about the evidence. And so what happens is they'll consult what the Endocrine Society is saying, for example, and then that's cited, that's cited in their decision. So it's, the Endocrine Society dragging their feet on this. Yes, it's harmful in terms of how it directly informs practice, but it also has these legal ramifications that are equally harmful.
Yeah, no, you make up, I mean, that's a great point for people to realize, and why we are trying to focus on, really laser focus saying, these guidelines from the associations need to be reviewed and need to be up to date. And we need to look at, again, our European colleagues who have done more of this, systematic reviews, because the associations are often cited in the legal cases, to your point, that, okay, we're just following, the science is settled, we're following, and, we don't want to be on the wrong side of harming kids. And, I think it's important for people to really dig deeper into understanding how up to date the guidelines are, how responsive the associations have been to doctors and parents who've had concerns. I mean, that should be a red flag, right? That if a society is just kind of ignoring all these people that have concerns, and the guidelines, on one hand, people are saying, oh, we're adhering to all of this exactly, but on the other hand, when they're called into, question about that, oh, wait, no, actually, we see that some of your practices, like Jamie Reed has brought, to light in the gender clinic in St. Louis, like, wait, no, actually, you're not following those. So like, you can't have a, both ways. And so again, I think, Do No Harm has done a great job with bringing that to light and helping all of us continue with this conversation and help other doctors and clinicians to have moral courage, to speak out, because just one person speaking out can make a big difference. And to your point, like Chloe being there, I mean, it was amazing. There were doctors that didn't even know detransitioners existed, which seems hard to believe for all of us who've been really working hard to bring this conversation to light. And they truly were, you could see that they were like, wow, this is really wrong that this happened to her.
Mm-hmm.
So they are, very, very powerful in helping us with all that. But yeah, the guidelines in these reviews are cited as dogma, and courts are just taking them at face value. But you should mention that your work has gotten mentioned recently in legal proceedings, which is fantastic.
Yeah. And I when I alluded to earlier that letter from that 21 experts, I think that probably changes things on the legal front as well. Because yes, unfortunately, you still have the Endocrine Society or the Academy of Pediatrics saying that this is consensus, this is settled science. But now it's clear as day that that's not true from an international perspective. And so the case now, that assertion now is a lot harder. It's clearly not settled science. People have concerns about these things. So I think, that's probably opened up the legal front as well.
Well, I have a little bit of hope. The Pediatric Society, the American Academy of Pediatrics, is doing a systemic review. They've already concluded before that they think that their present guidelines are fine in this area, but they say they're going to do a systemic review and a systematic review. And I'm a little hopeful. I think that they're going to find that the evidence, particularly for the puberty blockers, is extremely poor and should probably be discouraged. I mean, that's my hope. I don't know whether that's going to happen.
Yeah, it warrants caution.
Yeah.
As Roy was referring to, when they made the announcement that they'd be doing the systematic review, they made some sort of statement, basically saying we're pretty sure, we're confident we have this right as it is, but just to indulge folks, we're going to, we'll do this systematic review, I guess. But, it's a very politicized organization, clearly. And so it's hard to have faith that this is going to be done in the way that it's supposed to be done. One of the things that I would be insistent about is if they reach conclusions that are different from those countries that have done their own systematic reviews, that needs to be explained because, they're looking at the same evidence. These are very modern healthcare systems. It would be strange for for that American review process to reach a different conclusion. So if they do, I think we need to insist on an explanation.
Right. And at least it's like the conversation is going in that direction where there's of course they said, oh, well, we stand by these guidelines of 2018. It's really a policy statement that was written by like a resident, or I think someone who was out of residency for like 1 year. And they're basically saying, well, we stand by those, but we're going to do a review. So again, sort of, splitting the difference, I think, but at least it gets a conversation going in the right direction. And hopefully, again, more physicians will speak out and share their experiences, and more detransitioners and more parents. So I think, that is definitely a great sign that there is an opening here to bring more and more people under, in the fold. So yeah, go ahead.
Or if any doctors are out there watching and you have concerns and you're afraid to come forward, please come reach out to us at Do No Harm. Look on our website and look how to reach out. There are ways that we could help you, and also, if necessary, protect your confidentiality. But let us be a partner to you in that journey.
Yeah, I put your guys' website in the chat. So absolutely, we love what Do No Harm is doing. They've been so great to have more people bringing these things to light. We've got some great questions, and our experts in the background have been putting some great answers in. But I'm just gonna look here, and an anonymous attendee wrote, does this mean Europe is also limiting medical transition of adults? The culture of gender affirmation in America seems to support the idea that as long as someone is competent and consents, that they can receive any surgery or medication they want to affirm their gender. Should this be regulated in some way? So I think, yeah, there's kind of, question about adults, and then the general sort of, I think, consumer medicine culture that we have. I don't know if either of you want to comment on that.
So I don't, from what I understand, in Europe, adults are still getting treatment, the cross-sex hormones and the surgery. See, I'm pretty libertarian when it comes to adults. I think adults should be, because my main problem with children is children really can't give consent. Children are not, we don't let them give consent for all kinds of things, and all of a sudden to make such huge decisions is quite troubling. And so I think there should be more mental health care for all of these people, because a lot of them have concomitant mental health issues, and that's been shown by a number of studies. But I don't know. I don't think I would limit anything in adults. I think we should do a systematic review for adults as well, to see if we're actually doing. We actually are preventing problems in adults, but adults can give consent, and I think. We have to respect the autonomy of adults, but we also have to protect our patients from bad medicine. So a systemic review in all groups is probably warranted.
I think when we're talking about changes in Europe, it merits a little bit of conversation what that actually looks like. So for those countries that have actually reversed course, and that is really especially Finland, Sweden, and the United Kingdom, but also sort of statements of concern or wheels moving elsewhere, Denmark, France, Ireland, and so forth. But for those countries that have reversed course, they've not fully banned the use of puberty blockers in children. They're confining it to clinical research settings and using it for what they're calling exceptional cases.
But that will cut down the use substantially.
Oh, of course, and it is. What they're saying is that part of it is that there really is no good data on this, and so we need, you kind of need it in these clinical settings so they can actually, in part, procure the data that they need. In the United States, so they're saying basically the vast majority of kids who were getting this before should now not receive this form of so-called care. In the United States, unfortunately, the pipeline from, or the process from expression of dysphoria to medical treatment is very rapid. I think it was the American Academy of Pediatrics that said that watchful waiting is harmful and outdated. And so their recommendation, and unfortunately, we see the schools kind of playing along with this idea, is that as soon as a child is expressing any sort of gender incongruence, they should be, you should initiate social transition. They should be called by their preferred pronouns. Then they start talking to a therapist. And then unfortunately, it's a very short amount of time, weeks or months often, until they start on these powerful hormonal treatments. And so, for me, given these questions around consent and given massive concerns, the sensible thing is to not make these treatments or so-called treatments available whatsoever. But at least in Europe, they're recognizing that there's a lot of kids who are getting it who shouldn't be getting it, and a child simply saying that they're a girl in a boy's body, it's not a compelling reason to start this process.
And many studies have shown that if you do watchful waiting, 60 to 90% of these children either will turn out to be gay or the gender dysphoria will pass. So, we really need to be careful, because these are lifelong things. And you're not talking about giving kids drugs for a year or two. You're talking for the rest of their lives. You're talking 50, 60 years. We have no idea what it is to give cross-sex hormones to people. And we've had instances in the past where we've given hormones to people for periods of time which turned out not to have ended so well. So I think we really have to learn from our past and learn to go slowly and learn to do this in a systematic and an organized way. And I don't think that's what we're doing right now.
So I'm a numbers guy. The thing that scares me is, you mentioned that somewhere like 80 to 90% of kids who express dysphoria will see that resolve naturally during puberty. The puberty itself is what resolves that feeling. So historically, you have 80 or 90% where that will resolve. But now those kids can be put on puberty blockers, and something like 98% of those kids put on puberty blockers will proceed to cross-sex hormones. And so you can see, just in terms of simple arithmetic, why this is a concern. What the activists would say is, well, the fact that they're proceeding from the blockers to the cross-sex hormones is proof, actually, that they were correct. But what it really is, and this is what the review in the United Kingdom says, is that putting them on puberty blockers, it's not this neutral act of just pausing puberty, as they call it. It is a very powerful signal that the child is correct in that belief, and that it's appropriate to medicalize that feeling. So that's how we get there. But those numbers, I don't know how those numbers don't scare people, but it's it's a problem.
I also think that the detransitioner rate is much higher than anyone is actually saying. And unfortunately, I think part of the way this is going to resolve itself is the American legal system. There are already multiple lawsuits in the United States. There are lawsuits in the United Kingdom. There's even some in Canada, from what I understand. This may turn out to be a problem later on. And I think we need to be very careful how we proceed on this, because as Ms. Cole has told us, a lot of this is not reversible. So when you detransition, a lot of this is not reversible, and it can lead to lifelong consequences. And some of these children are going to wake up and say, "Why did you, my doctor, and you, my mental health professional, not tell me all this?"
Yeah, those are such great points you guys highlighted. I mean, our part of the consent process in the United States, really historically is this idea, everything's been reviewed with them, they're consented, so like I'm protected legally. I mean, that's sort of what I think these people are thinking. But of course, everything has just gotten also what we call sometimes in healthcare, like this McDonald's mentality, where there's a lot of short-termism. People want things really fast. And it just seems that there are so many things that had lined up with this idea that, oh, well, they consented, so there may be some issues, but I'm protected because I consented the patient and the parents. But again, there's somewhat of this static nature where they're not incorporating the information about people that are being harmed. And to your points, I think that a lot of those folks have been lost to like follow-up, they're sort of shunned as well. They don't feel like when they've tried to get help in the healthcare system that there are doctors that can help them. They're often told to just go back to gender clinics. As we've talked about in fair medicine, there's no billing codes for detransition. So there are, I agree that I think the cohort of young folks who have been harmed is pretty significant. And I think it's just gonna, keep growing. And so, this idea of, oh, they just signed a consent, everything is fine, doesn't really fully reflect how medicine is really practiced, and it doesn't really reflect what's going on with all these patients as you were highlighting. So yeah.
If anyone tries to tell you that they know the precise number of detransitioners, they're not being entirely honest. The activists certainly like to say that this number is trivial, and there's a few detransitioners like Chloe who are very vocal about what they went through. And so the activists will pretend that those dozen or so individuals, that, oh, it's just them and this is a rare phenomenon. That's clearly not true. If you look on Twitter, look on Reddit, there are clearly at least hundreds of detransitioners who are going about this, this tragedy much more privately. But, as I said, the number is not clear, but it's definitely not trivial.
So the other problem is we don't have a registry of these children, and we don't know what happens to a lot of them. So there was a recent study saying that people who had women who had mastectomies were all happy with their mastectomies for gender reasons, for gender transition reasons. But 41% of the patients, even in this small, short study, were lost to follow-up. So how do you make the conclusion that everyone was happy with this when you didn't even, almost half the people you were following, you couldn't follow? I mean, I don't think that's a very good science. What do you think, Ian?
Yeah. Well, it's also just a huge red flag. That's not how medicine is practiced. That's not caring people. I mean, if you accidentally chop off, the wrong leg once in a hospital, that's called a never event. It's not like, oh, well, there's just one person, I mean, it's like, you just don't, you don't do that. So if there's one person that is harmed, you have to figure that's wrong. We don't, what is going on here? And we have thousands and thousands of young people. And to also, another red flag is, again, to not care about them and pretend that they're just, they inconsequential is just so inhumane. So like, to me, that argument is just, it's nonsensical. That's just not normally how medicine is practiced. Yeah,
So
go ahead.
Chloe actually says it's hard for her to get care for things.
Yes.
That the doctors that initially looked after her are not interested in seeing her anymore. So, I mean, I think that's another thing that we have to deal with. We have to deal with that there, and the best estimates I'm seeing somewhere maybe around 30% of these of these patients detransition. So I can't say that's an absolute number, but that's the best number I've seen lately. Do any of our experts have alternate numbers?
I don't know. We'll see if they pop up and tell us, but it's a lot. And you know, right, again, it's heartbreaking to think of just this giant cohort of patients that are still, they're creating more and not wanting to look at the other side of the coin. I think someone put in here something about, you know, were physicians persecuted for opposing haphazard use of opioids, for example, or lobotomies, the way they were opposing gender medicine. You know, for me, my experience during that time, there was a very similar kind of pressure, sort of this giant regulatory apparatus around, you know, the pain scale and how that was tied to hospital reimbursements. And so there was a level of, you know, it's sort of an early version of the social credit system in a way that we've seen more with this gender ideology that, you know, if you're a quote unquote troublemaker in the hospital or patients are complaining about you, you know, your yes could be shunned. I don't think there was as much of people losing their jobs then. It was more like people just going ahead and writing prescriptions, or there were people that left the field of medicine. Obviously, there, you know, I mean, there were doctors that, you know, got killed because they weren't refused to write prescriptions. So there definitely was a consequence, but I think social media and the network effect with the internet is certainly taken it to, you know, a whole another scale. I think the lobotomy debate, I know there was a debate again between the pro and the con and the societies trying to duke it out, but there were people high up in societies that were pro lobotomy that were just thought to, you know, the science was settled and you're helping people who are mentally ill that have no other consequence. And the lobotomy that was never made illegal. It was replaced by really, you know, the phenothiazines and the antipsychotics that sedated patients. So I don't went on a little bit there, but it gets into whether our panelists think the transgender fad will fade as rapidly as it emerged. What do you all think, it really being, you know, involved with it in the front row like we are?
I don't know. I think that we've reached a pendulum swing to one direction and it's going to go back after a while because, but I mean, that's just a personal opinion. I don't have any evidence to that effect because the evidence so far is it's going gung-ho. It's become, the problem is it has become somewhat social contagion. There are schools in the United Kingdom where 30% of the girls have decided that they, you know, that they want to have gender dysphoria, and those are huge numbers. That, you know, it's hard for me to believe that this was going on for the last 100 years and we missed it.
I think fad is the right word, and like all fads, it will pass. You know, unfortunately, distressed kids and especially distressed females, they look for ways to channel that angst and anxiety, and this is the fashionable thing right now. I don't know if it's peaked yet. It's hard to say. Maybe not yet, but you know, yes, this will pass. The concern in the meantime is making sure that it sweeps up as few kids as possible to try to protect kids from this. You know, gender dysphoria, yeah, I'm not a medical doctor. Gender dysphoria, from what I understand, it is a real and it is a rare phenomenon. You know, what's the number? Maybe something like 1 in 10,000 historically. I forget exactly what it is, but this phenomenon is not, it's not new. It's just that there's been explosive growth. But I think the numbers that you saw historically before this became fashionable, that's probably where we can expect this to return to. You know, part of the debates that they've been having in Europe and part of the concern that's been put forth is you talk about a country like Sweden. The reason you sort of know that it is social contagion is that it's a very socially liberal country. So it's not it's not like this is something that would have been extremely frowned upon for a person to do 20 years ago. So it's not, in other words, it's not people suddenly finding it acceptable to go through this process. It's that it's become fashionable and popular.
Yeah, and also I think, you know, the big factor is obviously, you know, big pharma, and that the medical technology, the medicines are readily, you know, available. And I think folks who listen to our webinars frequently know we talk about that, you know, the big pharma started legally, they were allowed to advertise direct to consumer. I think it was like 1997. I might have the exact date wrong, but that kind of corresponds, I think, with a lot of trends we saw, like that I experienced with the opioid explosion, ADHD meds, SSRIs, kind of just a lot of consumer, you know, type medicines that I felt was like market making, you know, that then people would come in and you know, there was a solution for them. And, you know, the diagnoses also, people in the mental health field complain how the DSM has really been kind of so expanded that it's almost not meaningful anymore, because you could, you know, with the different ways you could get a diagnosis. And so I know that there's a lot of issues with that. And that has, I think, definitely played a role, because, you know, the way medicine is in the States, you've got to have a code. If you connect it with, you know, a medicine, and then there's some sort of regulatory statute, like patient experience scores, that was, you know, part of the opioid epidemic. You kind of have this toxic brew of a giant market that might be really overexpanding outside of the folks who actually really have the diagnosis. So in terms of a fad, God, I think in some ways it is, but I personally think all of us, you know, are concerned about, you know, the overall mental health crisis with youth and the search for meaning and getting into all those issues. And somehow this medicalization has gotten caught up in it, beyond, I think, young folks who truly, you know, have the, you know, traditional strict, you know, definition of a gender dysphoria. Definitely the net has been cast out much, much wider. And again, we know that because there's so many people falling out afterwards saying this was the wrong diagnosis for me. So I don't know.
Also a question of,
yeah.
I mean, there's always been tomboys and slightly, and tomboy girls and slightly effeminate men. And I mean, we're a bit of a continuum on that. We never thought, you know, let's change the sex. That's kind of the thing they do in very regressive regimes like Iran. You know, I mean, you know, I find it very strange that we're now looking at strict gender roles for people now. Than before we were saying anyone could do anything, and now we're saying there should be strict, you know, the boys should be strictly one way and girls should be strictly another way. I say let them do as they please.
I think there's some
Yeah, go ahead, Ian. Yeah.
the dog caught the car phenomenon.
Yeah.
With gay marriage and with gay rights, like I think for the most part it appears to have been settled both as a legal matter and as a matter of public opinion. And so you know, these activists unfortunately weren't just content to you know, take that victory and go quiet into the good night. They sort of lurched onto this cause and decided, you know, no, this is the new real civil rights issue. And so you have a lot of people coming into this, I think, you know, with ostensibly good intentions, but with very bad outcomes.
Yeah. Hear me okay? Yeah, I think that yeah, people obviously, you know, good intentions and don't want, you know, people to suffer, be uncomfortable, but I do think, you know, it is that broader conversation about, the fact that there is no zero suffering, and, you know, pathologizing puberty as like a disease, and also character it's like, you know, you can't live through, you can't deal with the discomfort, you know, is obviously a message that, you know, we all know, you know, is unhealthy, because you're going to have challenges and things. So I think those messages are also some of the things that all of us are concerned about, of, you know, comfortably non-medicalizing people into a state that, you know, isn't real. Again, we know because they come out the other side, and then certainly these people still seem like very angry. So if they're getting everything that they want, I'm not sure why they're so angry all the time. But you know, someone's writing in here, and our experts helping to, I mean, we've got unbelievable experts helping with our volumes of questions, but kind of along these lines, you know, how did gender ideology become so entrenched in science and medicine? And why are so many professionals so afraid to publicly oppose it? I know our volunteer expert did answer that in the Q&A, but I'd love to, you know, hear from you know, you guys.
Medicine has always been a sort of a, you know, a monolithic kind of thing. Remember, there some of the great discoveries in the last era were called crazy and by the medical establishment. The guy who discovered that ulcers were caused by a bacteria was basically driven out of Australia by his contemporaries for telling him that he was completely out of his mind. You know, you have to look at the evidence and go where the evidence is. And unfortunately, sometimes medicine isn't very good at that. And the other problem is the regulators. So once the regulators have an idea in their head, if you disagree with the regulator, you lose your license. And I think a lot of people don't do this kind of medicine. I would, you know, I would guess even if only a fraction of the 18,000 members of the Endocrine Society have read these guidelines, because most endocrinologists do many other things besides this. So, and then there's this DEI thing that has become the diversity, equity, and inclusion thing that has become a big deal, and you don't want to be accused of not being inclusive.
I think that's part of the answer, right? That's a big part of the answer. How did this become so entrenched? I think whether you're talking about DEI, diversity, equity, inclusion, or pediatric gender medicine, it's not necessarily the medical field setting the tone, although they certainly have an important place to play, but it's, if anything, I think downstream of just a larger culture shift, call it wokeness, this, you know, sort of fascination, this prioritization of kind of radical ideas about gender and race. This is just, it's that sort of larger vibe shift taking root.
Yeah, and I also think just, you know, since in our country with Medicare, Medicaid starting in you know, the 60s, and how the cultural medicine shifted with that then becoming, you know, part of something that physicians now, there was like a whole, you know, government apparatus you had to be involved with lobbying, which is how some of these, you know, associations really got going, even though the AMA had been around for a long time. But you needed to have a seat at the table, because then relating to price and other kind of things. And then I think, you know, more recently with the ACA Obamacare, where, you know, not to get too in the policy weeds, but, you know, one of the regulations 1557 that basically wrote in the civil rights language into healthcare law, you know, so before that, of course, civil rights law in the 1960s was the law of the land. So you couldn't discriminate in hospitals or anything, but Obamacare specifically wrote regulations in. And so then what happened, I think it did create this next wave of people in the hospital and regulators that had to make sure, or compliance people in the hospital, they have to make sure that, you know, they're not running afoul of any type of, you know, discrimination perceived, and prove that they're not. But I do think then activists take that as a call to action in a way, because as healthcare has gotten more expensive, people get very creative about how they can get their things paid for. And if you if you're not in the insurance stream, in our country, things are extremely expensive. That's obviously a whole nother conversation, how the price signals are messed up. But, some of this I see, again, I do feel people feel very strongly, but some of it is that they know they have to figure out a way to get these things paid for. And we're basically a subscription model in our country. And so if you're not part of the insurance stream, you can't get things paid for, and the hospital can't get reimbursed. So I think it just gets back to it's like, I think that's how some of these things get entrenched. It's not coming necessarily from doctors. I didn't see people running around saying my pain's not controlled, my pain's not controlled. But the initiative came down from somewhere like it just kind of, all of a sudden it's like you had to do the pain scale otherwise, and you had to have a certain score, otherwise the hospital wouldn't get reimbursed. But it wasn't based on anything that we saw going on with patients. So I think that's, unfortunately, we're in a very accelerated phase with that, is how I see some of this. Again, I've never seen racism in healthcare at all. I practice in the Black community. There's a triage system that's based on the acuity of your medical condition. It has nothing to do with skin color. So, there is no problem with systemic racism. So where all of a sudden that came out from, again, not something that we see, not I've ever seen in the practice of medicine. I think it's a big problem. I don't know the answer how to solve that. I'd be curious, Ian, with your work, and I guess Roy, you're up in Canada. Have you, what successes have you seen at trying to change some of these deep-rooted regulations?
Well, in Canada, we have many more regulations. We very much ration care in my country, and that's a whole other discussion. But the DEI stuff has gotten very entrenched there too, and that's become a bit of a problem, because apparently everyone's a racist according to the present government in Canada, but that's another story.
Okay.
I saw a question addressed to me about the right puberty.
Yeah, do you want to answer that?
So I don't know how to answer that question, because we have no way of actually judging what is right and what is wrong in terms of puberty. In terms of happiness scales, but I don't know biologically if this is going to turn out well, because we have to now look what's going to happen to these children who are on cross-sex hormones for 30 and 40 years, what their long-term outcomes are. And I'm not sure what's going to happen. I'm not sure if there'll be increased rates of cancer, increased rates of blood clotting, and other things. So I'm not sure if this so-called right puberty is a better puberty. I don't think there's any way of us knowing, unless we do a long-term longitudinal study looking at these children and seeing what happens to them over long periods of time. And no one seems all that interested in doing that, from what I can see.
Just so folks understand how this actually works from the evidence side of things. So for the most part, like what studies do is they'll just track these kids or these young people for a short amount of time and ask them questions like, are you happy that you got a mastectomy? Yep. Okay. Well, the process works. That's not rigorous research. If you're conducting rigorous research, you're supposed to have, ideally a control group, like a randomized treatment. And if not that, at least some sort of comparison group to understand whether the outcome is at least speculate on whether the outcome is better than what would have happened under other conditions. But, just asking them for 6 months or a year after, are you happy you did this? Like, that's not it's not rigorous evidence. And you know, even asking that question isn't really getting to the heart of, or the source of the concern. Like, people are, you know, proud and they're defiant, and people who have been through this probably have, you know, they've maybe lost some friends or family members. And so it's hard to admit, you know, maybe that this isn't everything that I thought it was. So really the question, you know, the thing that researchers should be trying to entertain is, are they happier? Are they healthier? And you know, there's no studies that do this in a rigorous way.
Right. And I think it's also that we've mentioned is that there's a big problem with follow-up. So even the studies that have been ongoing, there seems to again be this like blind spot ignoring the follow-up is so poor. And so you're just again making, you know, these conclusions that aren't very sound, but you're making them on such a limited sample size. And again, I think a lot of us feel that ignoring the young people who, you know, feel that this didn't work and that they were harmed and having all these consequences, and not really wanting to track all that in a systematic way. You know, we haven't really gotten into, you know, all the issues around all the prescriptions that are written, and how there's really, you know, doesn't seem to be a lot of discussion about the polypharmacy and all the different medicines that these kids and young adults can be on that could have adverse effects. It again seems to be falling outside the normal safety guidelines that we practice in healthcare, with checking on adverse effects and also just the dosages. There seems to be a lot of, you know, like what we call doctor shopping. I mean, prescribing from different people. You know, Planned Parenthood is got a lot of prescriptions going out the door, but there's no, you know, looking at all of that and the level of exposure. I mean, I know Chloe was saying that, you know, no one ever really sat down and looked at her whole entire medication list, but they kept like adding medicines. You know, when she said she was feeling, you know, depressed, they added, you know, like an antidepressant. And instead of sitting there thinking, well, gee, I wonder if what we're doing is the problem. So that is, again, kind of echoes of some of the things I saw when the opioid epidemic really got going. It was sort of ignoring the fact that people were like having overdoses and couldn't get up, you know, to go live their lives because they were so sedated. And then just prescribing more medicines on top of that. So, yeah, so I mean, along those lines, what would be, you know, looking into the future, what would be in the United States where you think like an ideal, you know, study that we could do that would be, you know, ethical, obviously, to help us really understand what's going on with these kids? If you could just, you know, have a dream scenario, what would you guys say? Oh, you're muted.
I think we need to have a registry of all these children and follow them longitudinally for long periods of time. And we've done that before with other illness, with other diseases, with other conditions, and, you know, and see what's going on with them. You know, the problem, we should also probably do double-blind controlled studies, but the problem is that people tell me that the science is settled, so you can't do a study not treating these children because it would be unethical, because it works, but we don't have evidence that it works. So it's a circular argument. So I think at least longitudinal studies comparing these children to other children with similar ages and backgrounds, even if they're not gender dysphoric, and see what happens to them, and compare rates of mental illness, compare rates of suicide, compare, you know, all kinds of things like that. But Ian is the real expert in terms of study design. So,
yeah,
you know,
what do you think?
The reality is, the U.S. being this laboratory of democracy, now we have states taking different approaches. So there are a lot of states now that have banned this practice for children. And so we're a few years out from having the data, but that is going to allow researchers to look in a pretty rigorous way what the effects are. You know, the activists are claiming, of course, that this is harmful. It's going to lead to greater depression and greater suicide. We're a few years away from being able to evaluate that, but the data will be there. But, you know, I echo Roy's point, because unfortunately, a lot of times detransitioners are just sort of swept under the rug. They're, you know, they're deemed as sort of inconvenient and, you know, just get out of the way and be quiet. The healthcare establishment could do, I was going to say a much better job, could do a job of trying to actually really, you know, locate these people, talk to them about their experience, track people who are going through this process. You know, it feels like they're purposefully sort of doing, you know, purposely covering their eyes because they don't want to know the answer.
Yeah, that's heartbreaking. And I know we all are committed to really helping these young people, you know, by getting this information out and really trying to connect them to resources. Again, it reminds me of the time where, you know, it was just like the amount of overdoses piling up, and just the regular people just didn't seem to care. And the hospital was like, well, no, we get paid, the pain score has to be done. And, you know, they didn't have an answer for that conundrum. And obviously, you know, there were people prescribing inappropriately because they were, you know, I personally never did that, but it was, you know, there was zero support, but they ignored all the overdoses. So it's kind of similar, ignoring, you know, the detransitioners. So we're coming to close. We have a few minutes left, but, you know, I also kind of along these lines wonder if you both could just share what, you know, how you think, you talked a little bit about, but how you think it will, quote unquote, end in the United States, thinking that there is going to be at least an end to the explosion of this. You started to talk a little bit about the differences in the states. Like, do you think this is going to go kind of along the way abortion's gone in our country? You think it seems like it's going to go up to the Supreme Court? Do you have any thoughts of, you know, what might happen there? And you know, if regulations could be changed, you know, what would be some thoughts of things that you would change? There's kind of a lot in there. So I don't know, Ian, if you want to go first, and then Roy, and then we'll close it out.
Sure. So as I alluded to, there's already a lot of states, I don't know, 20 or so that have banned this practice, and there will be more to come. You know, for the foreseeable future, for the short term, unfortunately, there are a lot of states who aren't going to do that. And so, you know, what do you do in those states to protect those children? It's not going to be easy. I mean, it's certainly not hopeless. The reality is that public opinion on gender ideology is changing. People are growing tired of this stuff. From public opinion polls, actually, the percentage of people who believe the foundational myth that sex can be different from, that gender can be different from sex at birth, or however you want to say it, the number of people who believe those can be different is actually shrinking every year. So this ideology is in decline. People understand that it's crazy. You know, the problem is that, like, we can all see that this is crazy. It's out there in plain sight. With, you know, even compared to like the DEI stuff, for example, like it asks us to, you know, to sort of take as an article of faith things that I can't fully know, you know, maybe someone is treated differently on the bit. Like there's a shred of like not knowable stuff in there. But we all know what a man and woman is. And so I think this myth can only, you know, this idea can only continue for so long. It'll run out of steam.
You think it's going to go up to the Supreme Court?
Not a legal expert, it certainly looks that way. You know, it's hard to envision a world in which the Supreme Court would, you know, would say that states have to provide this. I think the question would be, you know, whether they say this is a states' rights issue like abortion, or even potentially to say, you know, this is not healthcare, this is harm and this can't be allowed. You know, it would seem to me that sort of decision's not out of the question.
Right, like forced sterilizations that were going on for years. I mean, they, you know, eventually ruled that you can't do that. But like in Virginia, I think it was up until like 1977 that they were doing those things. But yeah, Roy, what do you think? I know you're a Canuck, but
So I think your legal system, the trial lawyers of America are going to fix a lot of this. I've already heard of a couple of law firms who are specializing in detransitioners. And I'm hoping that systematic reviews will yield at least some relief in these areas, because I think that the evidence for the puberty blockers is very poor, and I think the systematic reviews are going to show that. And I agree with Ian. I think that parents are, first of all, parents are going to get on board with stopping this, because at some point, you know, they're going to see that their kids in the long run are not necessarily any happier that they've done this than they've not done this. And I think that's going to be part of the problem. You know, I don't know why we're exposing children to this in the schools like this, because it seems to be sort of a propaganda thing from the NEA and teachers that you know, yes, be inclusive, accept diversity, but you know, you should also respect people's families and parents. And in Canada, at least, you can transition without telling your parents. You know, I mean, it's a very Marxist way of thinking that parents don't know their children better than the state.
yeah, and we do, you know, I think in Oregon, we have that issue. Here's our surprise guest, Lior, who's been in the background helping me. But did you? Well, first, let me read about just the studies, and then I want you to talk a little about the legal aspect. But we have just a response about, even if we don't run a controlled trial, we know that the Branston uncontrolled observational study, the Swedish registry study, there was no clinically significant improvement in mental health from hormones or surgery. If improvement were going to be seen, this would have been the place it would have been seen. So I wanted to make sure everyone heard that. So Lior, why don't you take it and give us your wisdom on the legal aspects?
Well, just two very broad reflections. One would be in terms of the mechanics of how and when it gets to the Supreme Court. I think it will get there. It's going to take some time, but usually the conditions for getting to the Supreme Court is that you need a circuit split. So, you know, you have to have a few federal circuits that allow these laws to go forward and a few that block them. And it also helps that the U.S. Solicitor General recommends that the Supreme Court take up the case. And that's going to depend a lot on the ideological balance on the court and on which party is in office in Washington. So that's one reflection. The other is that the Supreme Court is, because of the way in which activist organizations like the ACLU have framed this issue, they framed it as a civil rights question with medical implications. Whereas what it should be is a medical question with civil rights implications. But the consequence of framing this as a civil rights issue first and foremost is that, you know, the Supreme Court is going to probably have to issue a decision under the 14th Amendment. And that means that the court's gonna have to decide what is the proper standard or standard of judicial scrutiny for equal protection claims. What we saw in the 11th Circuit a few days ago was the circuit court basically say these types of cases have to be adjudicated under the least exacting standard. It's called rational basis review. And once a court makes that determination, these laws are almost always going to survive judicial review. If, on the other hand, the courts say, no, we're going to review them under the intermediate or strict scrutiny, and I don't necessarily think that there's much of a distinction between those two things, these laws are almost always going to get struck down. So the Supreme Court's task, it seems to me, would be first and foremost to clarify if these laws are going to be adjudicated under a civil rights framing, and I don't think they should, but if they are, what is the proper standard of judicial review?
Oh, he's gone. I was hoping you would.
No, I'm here.
Oh, okay. I didn't know if you wanted to say anything else about anything else we had been talking about, just to kind of close it out. Like, each of you say something, but I know there was a lot in there about, and you've done so much work on the associations and whatnot. So, like, please share, your additional wisdom.
Yeah, I mean, I think one thing to note is that, these medical groups, they build themselves as professional medical associations. I think they're better thought of as associations of medical professionals. These are trade unions, first and foremost. And I think when people are trying to, when we are trying to explain to the persuadable middle why this kind of pseudo consensus that has formed on the issue of gender medicine should be taken with a big grain of salt. I think one thing that's I think a useful analogy here is to the teachers' unions. I think most Americans readily recognize that although the teachers' unions are staffed by people who care deeply about education, in any situation in which the interests of teachers or of the union itself come into conflict with the interests of students, meaning the interests of students to learn, the unions are going to prefer the members and their own institutional interests. And they don't do that because they're cynical actors. They do that because their incentives force them to. And in the same way with the medical associations, I think we're seeing that with Endo right now. We're seeing that with the AAP. WPATH is a bit of a different story. But with these two organizations, at least, as long as they perceive that their own institutional interests and the interests of their members, especially their most active members, people who sit on their committees, who participate in their meetings, as long as these organizations perceive that their incentives are to side with the doctors who have come out publicly in support of gender affirming care, that's what they're going to do. I think whether that ever changes is going to depend in part, I mean, there's a number of things that could change it, but in part on whether these institutions have leaders who can think of their long-term self-interests, because these organizations are destroying their own reputations piece by piece. And it's going to take a really strong leader to understand that that reputation, once destroyed, is going to be extremely difficult to build back up.
Yeah, well said. Thank you for popping in and sharing and helping behind the scenes. And I just want to thank Roy and Ian as well, and make sure everyone knows to check out Do No Harm. They're doing fantastic work, and we're so glad to help whenever we can get the word out. We all, kind of collaborate together because we want people to have conversations. I want more physicians to step up and be brave and speak out about these things. So with that, I think if Roy and Ian want to just say a closing comment, and we'll sign off after that.
I don't really have much else to say. Okay. I think I very much appreciate Dr. Sapir's comments, and thank you so much for hosting us. And yes, go to the Do No Harm website, especially if you're a physician.
The legal fight here, of course, is critical. A lot of this is going to be decided in the courts, but This is a philosophical and a political battle. And please go out there and make your voice heard. And, again, if Do No Harm can be a resource to you or help you in that, then, please come see us.
Great. Okay. Thank you, everyone. Good night, and we'll have more webinars in the future. Okay, take care. Thank you. Bye.